Hi, I'm Frank from the Frank and Lacey Show, and today I have something exciting. I'm going to answer three questions that most people ask, whether you're a patient or a clinician. Number one, what is lymphedema? Number two, what does the lymphatic system do? What's its role? And number three, the burning question, how can I tell if a patient or my family member has lymphedema? And I'm going to tell you that make sure you follow us. We have a channel, we have a website, frankandlizzieshow.com. We have guidelines, we have a lot of videos for you. So please make sure you subscribe. But for today, let's go ahead and get started to answer our three questions. And so when you look at the diagram on the right-hand side, it's the arterial system, the venous system, but a lot of people don't realize that the lymphatic system plays a huge role in our daily function. And so without a lymphatic system, we have problems. And so the burning question that I mentioned is, how do we recognize lymphedema? Statistics show that 90% of the time you can tell that you have lymphedema just by doing a good physical and also a history taken. And so make sure, stay tuned because I do have a lot of cases to show. But to answer, number one is that lymphedema, by definition, is a chronic progressive failure of the lymphatic system. And that's important, the key word progressive, because if you don't recognize it, then that means that you're not going to capture it and prevent the further outcomes. Now, we have fluid accumulation, which leads to tissue damage, and you have the increased risk for wounds and infections. And in history, I've seen patients been amputated because we didn't know that that was a lymphatic problem. And so I will tell you my experience, 37 years in chronic wounds as well as now lymphedema, and putting both of them together, it opens my eyes to a lot. So I do teach, and I do want to thank Norton School of Therapy for allowing me to use some of the slides, as well as also Karen Ashforth. Karen Ashforth, phenomenal occupational therapist, and she talks about the fibrotic skin. So listen to her as well. But if you look, the progressive disease of lymphedema, if you look at her stages on the bottom right-hand side, you're going to see that, and by the way, this is not the same patient, but you're going to see stage 0. You don't see any swelling. Stage 1, you can actually see there's a difference. And if you capture it here, it won't progress to stage 2 and 3. And 3 is what most people recognize. By then it's too late. Now we're working harder where we could have made it easier in the early stages. So stay tuned because towards the presentation, we're going to talk about how to look and define what lymphedema looks like. And so as we continue talking about lymphedema, it's an abnormal collection of protein and water in the interstitial space. That's right. And when we look at it, we know that it affects usually one side of the body, but it can affect both sides. And the swelling can occur anywhere in the body, the legs, the arms, the trunk. And the trunk is very important to note because it helps for treatment, but it can also affect the head and neck and also your genitalia. And so there's a lot of intricacy when you start looking at what lymphedema is. But regardless, it's a mechanical damage of the lymphatic system and it's still progressive. And if you look at the top pictures, I'm going to show you pictures so you can see. This is somebody with lymphedema. You can see it affect the toes. And so in the wound care setting, we have to realize that we compress from the metatarsal heads up to the below the popliteal area, but we sometimes forget the toes. So we have to make sure we address that because otherwise it's uncomfortable and again, it's progressive skin problems. On the bottom, you're going to see that's a patient, but also there's more comorbidities. This patient has diabetes as well and other problems, foot drop, as you can see. And so it is complicated, but you can see one leg is bigger than the other. And keep that in mind. But as we go, I'm going to tell you that we have stages of lymphedema. And stage 0, this is where we have it, but we don't see any visible swelling. This is why we miss it, because we're not looking for it. But the patient may complain of heaviness, achiness, maybe tightness, okay? But we know something has been damaged. So when we do the history later, we're going to talk about the stage 0s so you can prevent any further problems. Now, stage one, as you progress, let's say we missed it at stage 0, we go to stage 1. Now we have pitting edema. It's not hard. This is just starting. But the name reversible means that you develop swelling, but then you either elevate it or you go to bed. And when you wake up the next morning, it's gone. So this is early, but this is what we have to be more attentive and respond because we can prevent further staging. But let's just say we don't do anything about it and it progresses. Now you have swelling. At the end of the day, you go to bed, you wake up in the morning and it's still there. So that means that we're not removing the fluid from the interstitial space. And this fluid, which will go, you got to know what the makeup is. This fluid will start creating irritation, inflammation. And so towards the end of stage 2, now we develop hardening of the skin, fibrosis. Okay. Now there's increased risk of infection. But we didn't do anything in stage 2 and the patient progressed. Stage 3 is the last stage. And a lot of people think that if you have a huge leg or a huge arm, that you have stage 3 lymphedema. Well, I'm going to tell you it's what happens to the skin. If this lymphedema patient develops an ulcer, then you have stage 3. There's risk of infections. There's also recurrent infections. Patients get readmitted to the hospital because of these infections. The other thing is that you may see skin changes, papillomas, you may see cysts, you may see fungal infections. And so we have to be attentive and do a terrific skin assessment because this is what's going to get us to where we're going. But early recognition and appropriate management is the key for these patients. So, real brief, the purpose of the lymphatic system, a fluid balance. And this, we try to define it with the Starling principle, Starling law, where pretty much when you put fluid into an object, the fluid has to be also removed. And so if one side, if the filling side or the output side is not working right, you're going to have overflow of that fluid in that bowl. And so the primary purpose is fluid balance, which we're going to talk about. Secondary, you have immune surveillance defense, and it also helps with transportation. And so, but the burning question, here's the key. Recognize the lymphedema in your patients. You can do a quick assessment and be able to tell, but you have to make sure that you do a good history because you have to determine which type of lymphedema it is. And don't worry, because once you recognize it, similar symptoms, similar characteristics, the treatment's the same. So, and this is just a chart that I wanted, and we're only going to cover the first 2. Just make sure that we ask, was there a trauma to the lymphatic system? And if we do, we may see some physical attributes to it. So we're going to talk about all these through the presentations, and I'm going to show you images so you can determine if your patient has lymphedema. But let's understand the anatomy before we get there, because a lot of people, actually, my last patient said, oh, this is voodoo. But when he started getting better and when he started seeing exactly what I told him, he bought into the program. But let's understand the lymphatic system overview. Okay, there's a superficial lymphatic system and a deeper system. What we treat as lymphedema therapists is that we treat pretty much a superficial system for the most part. And so what I want to highlight here is the final connection, because a lot of people say, where does it end up? It's an open system, but where does it end up? And so the lymphatic system has to end up in the venous system. And that happens around your neck. So if you look at this picture, and I'll use the pointer, the connection between the internal jugular and the subclavian vein is where the lymphatic system ends. On this patient, it's on the left side, okay, but there's also a right side. So left and right. And so this is where the patient will take all this fluid, and this is why a lot of our patients, when we start treating, they go to the bathroom more often because it's going through their kidneys. And so the other question is, what drains into this left side and what drains to the right side? This is a good kind of thing to review because our patients, you have to know where the problem is. And so the right venous angle, which is what we call the junction between the internal jugular and the subclavian, this is where it drains areas from the right side of the head and neck the right arm, and then on the trunk is going to be the anterior, posterior, upper quadrant. And so all of these areas drain into that right venous angle. On the left side, everything else. So you have the arm, the head and neck, both legs, but also keep in mind the genitalia and the GI trunk. And so we have a lot of volume in a 24-hour period of time that goes through our system, usually 2 to 4 liters. And so the lymphatic system is very important because it drains, it keeps that balance, but it drains all the toxins and all the waste products through the lymphatic system. And so looking at anatomy, because again, a lot of people don't understand what the anatomy looks like. And this is just kind of a brief explanation where you can see this platform down here is your fascia. Anything above that is your superficial system, which in my world is about a nail thickness. So we have to be very careful how we treat our patients. Anything below the fascia is a deeper system, but we're mainly interested in the superficial. And so the tree line is your lymph capillaries. And we'll talk about these, but there's one big player that we address when we treat, and that's the collector. That's this green pipe right over the fascia. And so let's talk about that real quick to understand this system a little better. So the lymphatic vessel, the collector that we're seeing here, it's just think of your bladder. It's got smooth muscle, and when it fills up, it contracts. And so the lymphatic vessel does the same thing. As it fills up with lymphatic fluid, it goes from one segment to the other because of the set of valves, which if you think of the venous system, it looks kind of similar. And so the collector, again, helps move lymphatic fluid through a caterpillar-like motion using the autonomic nervous system, using smooth muscle. And so there's a way we can elicit contraction when we're treating. And so just to give you an anatomy, especially the leg, because we do a lot of wounds, you can see these are the plumbing or the collectors that end up into the lymph nodes. And so this is your superficial system. And so any trauma along here, remember, nail thickness width or depth, you're going to realize that you may have fluid buildup. And so but I have to explain what is that lymphatic load so it can make sense. Because a lot of times the patients that I have sometimes are given diuretics. If they're using diuretics strictly just to remove the fluid and help these patients, that's not the correct thing to do. It may help temporarily, but please don't make the mistake. If the doctor's giving them diuretics for cardiac reasons or medical reasons, they have to take it because there's a good explanation for that. But let's talk about the fluid that we're trying to remove. The fluid has 4 components overall. Water, which we know, but it also has other fragments that are really large, like proteins, cell fragments, and also some fatty tissue. Now, or fatty segments. But the proteins is what I want to concentrate on because the proteins love water. And so if we have a damaged lymphatic system, we did say we build up more fluid in the interstitial space, but keep in mind we have proteins not being removed, and that's what causes the inflammation as we go through this process. And so keep in mind water, proteins, cell fragments, and also some long fatty chain acids. Now, I was fortunate to be part of a study. And this study, it was the first time I saw my own lymphatic system live. And so when we think of voodoo, this is the video that I show the patients because what we did here is we looked at a lymphatic system before and after a treatment. And what we noticed is that we can stimulate the lymphatic system to contract that smooth muscle a little faster. All right, so I wanted to show you the lymphatic system. And this is a study that we did, I was part of, and we injected ourselves 36 times with ICG green. And this looked at a lymphatic system. So I want to play this so you can see that it is live. Is the lower legs, and you're going to see the injection site is down here. That's why you can see, and you can see it traveling up the system. Now, of course, the speed was a little faster in order to do it for the video, but you can see that the lymphatic system does remove fluid, waste products, and all that. And so it is not voodoo, it's really existence. And so let's differentiate between the swelling that we see. When we teach this, we talk about edema, which is just water fluid. It's a symptom, and that means that you have a lymphatic system that's intact. Lymphedema is when the lymphatic system is damaged, and now you have that lymphatic load, which we talked about, includes proteins now staying in the fluid, staying in the interstitial space. And so this is why if we're giving lymphedema patients diuretics just to remove and make them better, then we're removing the water component of the lymphatic load, but we're leaving the proteins. So we're really not completely addressing the problem. And so Heather Hetrick, well, now Barnhart, and I did publish this back in 22. We wrote in 21, it was published in early 22. But we did say all edema is lymphedema, it was just a way to get catchy because we know all the fluid is being removed by the lymphatic system. And what we were trying to say is that if you have untreated edema, it will lead to lymphedema, a disease, and it'll be progressive. And so being in a wound center, not working with lymphedema groups, it really puts the patient at a progressive problem. And so we all know that when we have swelling and we talk about the diffusion distance, that means the distance from the capillary, from the arterial capillary to the tissue and the cells that need it is not very long. And so anytime that distance expands because of swelling, we know we're going to delay wound healing. Our immune system is going to be affected. This is why our patients with stage 3 lymphedema get frequent infections because the cells can't get there to the skin or the tissue to fight the infection. And so the cell doesn't get the nutrition it needs, and we'll see further skin problems. So in reality, if we don't address edema or lymphedema, then our wounds are going to be delayed. And so case in point here, and this is before we start talking about how to assess it, but I want you to see this. This is a patient that for years kept coming to the clinic with wounds. And of course, this is the venous leg ulcer. And when he came in, we knew he had good perfusion because we ran some more diagnostic tests, more invasive tests, because this patient was worried about his leg and it wasn't healing. But we knew he had good perfusion. But when we measure the amount of oxygen at the skin with a TCOM machine, we looked at the blue was 22.6 and that orange was 25.1 millimeters of mercury. So keep in mind that we always talk about if it's 30 millimeters below, no healing is going to occur. So this is why our patients that have extreme swelling not being addressed have a hard time healing. And I was at the conference just recently in Charlotte, and Dr. Five got up to the stage and she said the numbers of people applying compression to VLUs, it's very small, very tiny. I was amazed at the numbers, and it looks like we're going backwards. So compression is the key to venous hypertension, but we're failing to do that. And keep that in mind. And so I went further than that, and this is a head and neck lymphedema patient just to show you. We're only going to look at the nears right now, and this is measure tissue oxygenation of the skin. And so a different machine from the TCOM. And when you see blue, that means more ischemia. Well, of course, in the neck, you don't have ischemia, but what happens is that's the spot where he has a lot of swelling. And so that means that the diffusion distance is not allowing the oxygen to get where it needs to be. But I did ahead and I did a project with him. And of course, that's the blue spot that you see. But I did manual lymphatic drainage and I re-imaged after I did that. And take a look. I was able to increase oxygenation just about 10 minutes of manual lymphatic drainage. And keep in mind that I followed him longitudinal. So after 16 days, you can see more red means more oxygen. And so that means that I'm decreasing the swelling. And you can see from day after MLD to day 16, there's even less swelling noted there. And so what we do is we try to increase the oxygen by decreasing diffusion distance. And so There's a lot of studies that I'm going to mention, but this is your typical venous leg ulcer patient. And of course, they're in the hospital now for an infection. And so when you see this patient, what we did is we taught them what to do to avoid problems. And when I say that lymphedema is a progressive disease, but also I'm going to share some statistics to show you that venous leg ulcers untreated can lead to lymphedema. And this is one example. 6 years later, they come back into my wound care clinic, and this is where the patient now is showing signs of lymphedema. Skin changes. You can see the girth, you can see or the size, you can see the toes, the difference. And this patient, again, we could have stopped the progression if the patient was able to do what we asked them to do. So let's explain a little bit more when you treat your patients, when you see patients. And so in the lymphatic world, what we do is we divide the body into quadrants or territories. And so that's signified by the blue line that you see here. Now, superficially and in the anterior part, this is the only place that we have the regional lymph nodes or the lymph nodes that we want to address. We have them on the neck, we have them in the armpit, and we have them down on the legs. And so now when you start looking at the territories or quadrants, so this right inguinal lymph node addresses all the lymph superficially for the entire leg. Okay, so this right axillary lymph node addresses all the fluid and waste products from the arm and the front and the back of this upper quadrant. And so we know where we're going to see the problems based on the etiology. And so to give you a clear example, let's say the left axillary lymph node on the front anterior is out for this patient. And I'm sorry for the image kind of distorted. And so the yellow indicates where I'm going to see the swelling. I'm going to see it in the front. I'm going to see it in the entire arm, front and back. And also on the back side, I'll see it on the upper half too. And so I'm looking for swelling there. And that's my area that I'm going to concentrate to treat. Okay? Now, so when you look at your patients, there's two types of lymphedema. Primary, which you're born with, and it does affect the kids, and there's treatment for these. But you can see on the left side of this child's body, it affected not only her arm, her leg, but also her face. And so on the lower right, you're going to see that this is the arm, and there's a difference. But keep in mind, there's a condition, and it happens a lot, that people are born with lymphedema, stage 0, it's not showing. And then one day they have an accident, usually about 34 years of age, but also happens when there's hormone changes at puberty. And so those are two times where if I notice the swelling, it may be that. And so 90% of the time is secondary lymphedema. It's an insult to the lymphatic system. It could be surgery, radiation, which we know, trauma. A lot of times I see patients lately with a lot of total knee surgeries that over time they develop more swelling and they get a lymphatic disease. Cancer, filariasis, we're going to talk about in just a minute because I have to show you a picture of that, but also chronic venous insufficiency. This is huge. So if you have a lot of the patients in your clinic, which if you look at the statistics, 80% of the lower extremity wounds are venous related, then you're going to be missing a large population if you don't assess them properly. But look at this patient right here. You can see on the right side, you have the hemosiderin staining. So this patient already has venous disease on both legs, but you can see one leg is bigger than the other. That's the key characteristic. One leg bigger than the other. It could affect both legs, but still one will still be bigger than the other. And don't only look from the knee to the ankle. Look from the knee above also, because the thigh does get involved. And also, if there's a leg, there's a high chance that it could involve the external genitalia. On the male side, the penis and the scrotum. On the female, the external labia. And this does happen. Patients will not tell you they have it. You have to ask very carefully. So secondary lymphedema is what we see most, but this is filariasis. It's a mosquito-borne, and a lot of times if patients are coming from overseas and they have this massive swelling, it could be related to filariasis. And if you do this, don't worry, make sure you contact the CDC because they'll tell you how to test it, when to test it, and then they'll come back and give you that diagnosis. So let's go back to secondary lymphedema. A lot of the times we look at breast cancer. We have more survivors now, and the latest statistics from 25 is that 1 in 5 will develop lymphedema. And so we have to look at that. But if you look on these patients, this was back in the days when we did radical mastectomies, you can see the extremely large extremity, and with treatment, you can decrease it down. On this patient, it looks pretty almost normal, but keep in mind that this is a disease. You have to manage it. So there's no cure. So a lot of times I hear that we're going to cure your lymphedema and you don't have to wear compression anymore. I haven't seen that to be true. And so, but maybe one day something will happen, but keep in mind, this is managing for the rest of their life. And so the second patient was not as swollen and there was decrease, but it didn't go back to normal. And sometimes the longer you have the disease, the more fibrotic tissue. I'm going to tell you that it's not going to look more normal. It's still going to be larger than the other, but it's going to be smaller like these two ladies. So catch it on early. But don't be fooled. In our clinic, this is the patient that we see. And a lot of times we miss it right under our eyes. And so when you look at this patient, this came from my clinic a long time ago, and you can see that the left thigh and the left leg is larger, slightly larger. Now, this means the patient's got a lymphatic disease, so we call this now febrile lymphedema. Now, when it comes to my world, I still want you to call it lymphedema because there's another reimbursement side that we have to talk about one day. But the gold standard for these patients is no longer just compression, it's complete decongestive therapy because this is a progressive disease. If we caught this when it was just venous, compression, elevation, that would have done the trick. But now we have a lymphatic load in that tissue, which means we have proteins. Compression alone will not remove the proteins. And this is an article written by a good friend of mine, Dr. Wade Farrow. And what I wanted you to see is that, and I highlighted it, that Lipedema, febrile lymphedema, is due to an insufficiency of the venous or lymphatic system or both, in combination with both systemic contribution. And so this is a protein-rich fluid, and it was a well-written article. So if you want to go back, and this is in 2010. So early on, I said, what's a third hot topic, which is how do I tell if my patient has lymphedema? A good history. And so I'm going to go over with what I do with our patients. And so I'm looking for a family history. Did your mom, did your grandma, did somebody in your family have a big leg? And a lot of times patients will say, I remember we used to make fun of grandma's leg and we didn't understand it. And so it could be a family history. This is leading you to say it was primary. But again, it does not really matter at this point because the treatment is the same. Now, surgical, there should be a surgical history. Do they have cancer? If they have active cancer, we do have to talk about that at some point. Radiation, chemo. Do they have venous disease? Venous leg ulcers? Have they had trauma? A lot of times I had a little boy that had an accident and kind of ripped where all the lymphatic vessels converge at the knee. And so he had a problem with the lower leg because the swelling didn't have any place to go. A lot of our patients, fused ankle. Think of our patients that walk with a step 2 kind of gait. They're not getting a full calf pump mechanism. Obesity is one of the biggest topics nowadays because we do see a lot of our patients that have obesity and lymphedema. We also want to know for treatment's sake, do they have a cardiac, renal, or liver problem? Because if it's systemic, then lymphedema, complete decongestive therapy is not going to be effective. The systemic swelling needs to be addressed by the physician and provider. I also like to know sleep apnea, hypertension. A lot of our patients sleep in a recliner. Now, when it comes to observation, look for that key mark, asymmetrical swelling. It could be one leg or 2 legs, but it's still going to be asymmetrical. Is there any trunk swelling? A lot of times when it's the leg, because of where that quadrant line falls. Sometimes they feel bloated on one side because it's still affecting that one area. Look at the skin. Do they have wounds? Do they have hemocytic staining, fungal infections? And then comes the physical examination, which we can do a stemmer sign. We have to palpate. We got to look for fibrosis, skin condition. And I like to measure because, and you'll see one of the cases where I measure every 4 centimeters. And I'm looking for research shows that if there's a greater than 2 centimeter discrepancy, then you have lymphedema. And so I also created a little mnemonic looking at when I look at patients with lymphedema, I want to make sure they have good arterial perfusion. A lot of people don't, but I'm going to tell you that my compression is dependent on how good of arterial perfusion they have. And so I've seen tissue being traumatized when the patient did not have good perfusion. Venous system, we have to address the venous system. Sometimes there might be surgical procedures that need to be implemented, especially if they have a wound. Inflammation infection is huge with our patients. Because of that protein-rich fluid, you have recurrent infections. Lymphatic system, I want to make sure that I know what's healthy because it means that I have to move this stagnant fluid to a healthy area. So it has to go from the superficial system to the deeper system. And so the lymph nodes is what, the regional lymph node is what allows me to move fluid from superficial to the deeper system. And so if I have the right axillary lymph node out, I have to go to my neighbor regional lymph nodes to move the protein-rich fluid. And of course, edema. If you have swelling, things are going to slow much slower. And then you have to take care of the skin. You have to, if there's a fungal infection, you have to address that. If there's a wound, you also have to apply the right moisturizer or the right lotion. We like to use a low pH lotion, but there's different lotions out there. And so make sure that you consult with a lymphedema therapist because we have little tricks of the trade. This is a study that was done in January 2020, and I like this study because that's a patient that came from the clinic. And we're thinking venous leg ulcers, right? Nobody even thought about thinking of lymphatic function. Now, and this patient has been in compression for quite some time, but the wound was not healing. Well, Dean, what he did is 440 patient charged retrospective study. And what he wanted to find out was what's the number one cause of lymphedema in that population. And you can see clearly it was CVI. And so the reason for that is because the lymphatic system removes all that fluid. And when you have somebody with CVI not being compressed, which Dr. Five can give you the statistics and is horrible. So if we don't compress when they have CVI, you have all this fluid building up for a long time, lymphatic system wears out. And then you begin with the asymmetrical swelling, skin changes, and now compression alone is not going to do the work for our patients. We have to start thinking more of the lymphatic component. And there's different methods to treat, but the gold standard is still by lymphedema therapists. And so the thing about CVI you have to know is that 80% of the patients that come into the clinic have CVI. And there's no statistics to say how many of those have lymphedema, but we know a large percentage of them does. But 25%, up to 25% of your CVI has an arterial component. And keep that in mind. This is a patient that has CVI. He came from another location and compression. Nobody worried about the arterial component, at least you can see. And this is a true arterial patient combined with CVI. And so his wounds weren't getting better, they were getting worse. And so when they came to our clinic, the treatment changed. This patient, interesting, they came into the clinic and they wanted to find out what the swelling was about. She had a wound. Now, can you see that the right thigh, she's on her back, the right thigh is bigger? You can see that the right leg is bigger. So when we did a history taken, this patient had primary lymphedema, was involved in a car accident, got hit on that right side, and her leg started getting bigger and bigger. And nobody really knew what to do or what it was. And so it was lymphedema. Now, she was about 34 years of age. And so, like I said, lymphedema tarda primary usually happens about 34. And so again, the treatment is still the same, whether it's primary or secondary. But when you do a physical examination, you can do a stemmer sign. And that's when you take your thumb and your index finger and try to pinch skin on the second toe or the second finger. If you can't, let's say like on the right side, then it's positive. And this is a patient that has lymphedema. On the left side, that stemmer sign is negative. But keep in mind, these both patients have lymphedema. It's just the one on the left is early on. That protein is not leaking, creating inflammation, creating fibrotic tissue. On the right, that's a stage 3, or it could be a late stage 2, where protein is building up for time, and that's why we get that fibrotic tissue. And so the message is, do your stemmer sign, but keep in mind, if it's early on, it's going to be negative. And then vascular screening. This is a patient I just saw recently from one of the clinics I'm involved with. And of course, compression, and they wanted CDT, which they were on top of it. And so I happen to do ABIs with my patients. I do thermography and also want to listen to the waveform. And so right away, the ABI was 1.4. Now, there's nothing in her history indicating that she had a problem. And then the waveform, the dorsalis pedis was monophasic. And so I need help from the wound care clinic now to go back and let's see, does this patient have a true arterial component problem? She had a negative intermittent claudication, but she had no hair on her toes. Her nails were thickened on that foot, and she had shiny skin. And so that's kind of making me question. And so I'm working with a phenomenal wound care team. We're going to revisit that. She's having further testing. And before I apply the right amount of compression, I'm going to get to the bottom of training. And so I want you to listen to the monophasic waveform. Okay. It just sounds whoosh, whoosh, whoosh. And so that's the only reason why I'm questioning this before I go and put a lot of compression, because the compression that I use initially is usually with short stretch bandages. And so when you look at lymphedema, these are two patients with lymphedema, of course. The pictures were kind of reversed a little bit. You can see on the top right, that was when they came into the clinic. Top left is after treatment. And so keep in mind, this is a slow onset and it's progressive. Early on is pitting edema, but later on it becomes harder. Sometimes you have a positive stemmer, late stage 2, stage 3, sometimes a hump on the foot, but asymmetrical swelling. And you can see in both cases that we have asymmetrical swelling, but also cellulitis. These patients get readmitted to the hospital a lot. And sometimes they have something called lymphorrhea, which the smell will make you think there's an infection. Don't be fooled. And I listed all these for you because you want a differential diagnose. But what I will say is when you have bilateral symmetrical swelling, it may be a systemic problem that they need to have further medical help with before they come see us if they do have lymphedema. The other thing is on this patient, you can see that the buffalo hump on the foot. You can also see the one leg being bigger than the other. But what I want to warn you is lipedema is another cause that we need to talk about. But lipedema is when both legs are bigger, let's say, but the foot is not involved. That's lipedema. And treatment there should be compression. But these patients may develop lymphedema, which means that one leg will be bigger, and now it may be slightly different, slightly bigger. So now a treatment of complete decongestive therapy will be helpful. Okay, this is just a taste of what we're going to talk in our further videos and other videos. In complete decongestive therapy has to have these components: skin care, manual lymphatic drainage. Please don't call it massage because it's not. It's very light. Remember, the lymphatic system I want to address is like a nail thickness deep into the skin. Compression. There's two different types of compression. There's a lot of different, there's Velcro, there's short stretch, which is ideally initially. But again, if the patient has problems or there's issues, we may have to alter the type of compression. And there's something new out there called non-bandaging compression that's doing a lot of great work for our patients. But also decongestive exercises and education. And when you put all these together, the patient's getting what they need. And so keep in mind that this happens, we can use that throughout the body. But what I want to warn you about is please do not use TED hoses for patients thinking they're getting compression when they're walking. What we have to do is use other type of compression. And so TED hoses will give you 8 to 10 millimeters of compression, maybe. And what we're looking is far more than that. And so you can see this is the patient, and you can see the black marks on there because I measure both legs to see what the volumetric difference will be. And so compression's the skill. Make sure you talk to somebody because there's so many things to consider when you're ordering compression. And lastly, this is the first time I saw somebody put this together where they looked. I know the studies are older. There's not a lot recent. There's other type of research we can talk about, but this to me was interesting because these are different type of people that treated lymphedema differently, but no matter which method they used, they still had a good reduction. And so when we're looking at our patients, that's the goal, to reduce the volume. And so it is a very comprehensive type of treatment. Thank you for listening to this video because one, you have to be able to recognize lymphedema early on so you can have better outcomes. Now, make sure you follow us. We do have a website and we are on social media and we're on YouTube. So make sure that you follow us because we have a lot of educational videos, not just on lymphedema, but on wounds, ostomy, and much more. So thank you, and make sure you check our next video that we'll have soon.